Well, good evening, everybody. It's always difficult when we can't see the audience, but I gather there's at least 60 individuals out there. I'm Bill Allen. I'm the Chair of Joint Committee on Surgical Training, but also a member of the Project Board for Improving Surgical Training. We have done webinars before, but this is a slightly different venture for us. The programme I think you've already seen, and there's a series of topics where we'll be giving shortish presentations on what is IST, why we're doing it, why you should think about applying to join it, how the training will be done, how you can apply to get a post on the IST pilot, and the trainee perspective of how this is planned to develop. That should take us about 20 minutes. And then we're going to have a question and answer session. That's your opportunity to fire questions at us, and we'll do our best to answer them. I suspect there may be some we haven't got answers for, but that's the nature of developing a pilot. I have with me three colleagues who are going to pick up several aspects of the programme that I've talked about. Elizabeth Sharp is the core surgery TPD for KSS. And is a member of the Recruitment Selection Working Party for IST. Lizzie Elsey is known, I'm sure, to many of you as Vice President of ASSET. And Debbie Beck is the Senior Officer from Health Education England, KSS, who will give advice over the application process and also a member of the Recruitment and Selection Working Party. We would like you to send comments via tweet using the hashtag Improving Surgical Training. So I'm going to start with the background to why we are where we are, what we're up to, and why we're doing it. IST has come about for a number of reasons. Some of you will be aware of a document that came out 4 years now called The Shape of Training, which was an attempt to improve postgraduate medical training. As a consequence, Health Education England approached the Royal College of Surgeons to see if we could adopt the principles within the Shape of Training in surgical training, and it was very much a blank sheet of paper as how we could try and do this. And it was very obvious early on that, particularly in core trainees' experience, both GMC and JCSD surveys showed poor satisfaction with the quality of the training experience, not the least being this constant tension between providing service and getting training opportunities. The steering group, which took advice from a wide range of stakeholders, elected to look at general surgery in the first instance. And the key initiatives are very much focused on improving the experience. Surgical trainees want to do surgery because they want to proceed with a career that is a practical and technical nature with work in the operation theatre. And that's where one of the issues where we knew there were some problems with a limited exposure to clinical experience, excuse me, because of the clashes with service. So as a consequence, we've enhanced the opportunities of dedicated training time. We have looked at improving the relationship between trainee and trainer, which hitherto has had its limitations, and that has included looking at how we can enhance the roles of trainers. In addition, we know from good evidence that simulation, not only in terms of technical activity, but also the non-technical side of any service provision and indeed training, that simulation has a significant improvement on opportunities to develop skills and also to develop the understanding of how you cope with day-to-day work in the clinical area. The other issue that's HE are keen on, and indeed is gaining momentum significantly, is the what's been termed the extended surgical team, or now being referred to as the surgical care team, which includes non-medically qualified colleagues who work within the surgical care environment, working alongside trainees. And in many folks' experience, this has allowed trainees to get away from some of the service areas. The intention, as you can see, is very much to ensure that at least 60% of the working week is in training opportunities. So what are we doing? Following the discussions and the development of the programme, looking at these different initiatives, we were given the go-ahead by Health Education England to put into place a training programme. This will be a run-through process starting from ST1. It will start next August, so those who are appointed to the programme will start in programmes in a series of posts around the country and will be pursuing core surgery training in the first instance. I think it's important to stress that this is just not a core programme or core pilot altogether. This is a programme to run through all the way to the end of training with the acquisition of the CCT. There has been some concern that there's a change in the outcome of this process. In fact, this is not a change. The CCT will be identical to what is achieved now. It's just going to be, hopefully, a more enjoyable way of getting there. So therefore, there will be exactly the same curriculum, the core curriculum that was recently approved by the GMC, which those in non-pilot training will equally work to. But the intention is that the working environment within the pilot will be different. So improve some of the training opportunities, as I've already explained in the previous slide. General surgery will start next August. If you're in London, it will start in October, and then we'll get an extension to urology and vascular in 2019. The approach is intended, as I said, to have a much closer relationship between trainee and trainer, setting regular learning targets and ensuring that the trainee makes those targets and achieves the sorts of competencies both in terms of technical skills but also non-technical skills in a more structured way, with encouraging good quality feedback from the trainer, personal reflection by the trainee, and indeed their own self-assessment. And this is something that we've picked up in discussions with other professions, where an individual self-assessment does allow them to understand what sort of progress they're making. There will be a mixture of both elective and emergency surgery, because general surgery, in its widest sense, is both elective and emergency. But there will be the opportunity through the second phase of the pilot, which is into the higher surgical training general surgery, to develop the special interest as we do currently. The other addition that's new within this is at the end of training, the vast majority will have the skills to work in the normal practice of general surgery with special interest. But there are some small, complex areas of practice which currently there are fellowships, but they're not necessarily fully supported through a training process. And it's the work we've done with HE where there will be resources available to us to design fellowships in those more specialist areas of practice where there are a small number of consultant opportunities, so that will be built into the project within the context of the pilot. So that's, in a nutshell, what IST is meant to do. It's meant to improve the quality and the experience of training and to make it more enjoyable, so that we can get round some of these criticisms whereby core training in particular has been felt to be less than satisfactory, to get over the problems we faced with the service and training interface. I'm going to finish there and pass across to Elizabeth Sharp, who's going to take you through a little bit more detail from the core point of view.
IST, from the core surgery perspective, why do we feel that it is necessary? We know from the various GMC surveys that all surgeons, core surgical trainees, have the least degree of satisfaction, and this is something that needs to be addressed. And it's been addressed jointly by HEE and the Royal College of Surgeons. We know that a lot of core surgical trainees, their main aspect of work is service provision, with limited opportunities to train, and this is something that IST will certainly aim to address. With shift working, the traditional surgical team and the apprenticeship model of surgery has been lost, and the trainee-trainer relationship has lost that valuable elective regular teaching that was so much a part of the training that I went through. And a lot of the work is at night, and in many cases, actual training is very little. although that is not always the case. We know that the trainers very often, with current job plans and current demands on practice, have very limited time to train. And the aim of the IST, one of the aims of IST, is to empower trainers, to increase their professionalism and ensure that they have ongoing training in their role as a trainer to enhance that. We also know that the Annual Review of Competence Progression, the ARCP, is a very variable standard and lacks both consistency and reliability. There is currently a working party from the college that is looking to improve that and standardise it. And certainly that aspect of the IST aims to improve that, so that we know that the trainees that come out will come out with a consistent standard, that they will certainly be at the same level that our current trainees coming out of CCT are, and possibly an improved and enhanced training to allow them to provide safe care for our patients.
Thanks, Elizabeth. So why should you consider applying? We're obviously the enthusiasts, and we're going to try and put that across to you why we think this is an opportunity for you as you embark on your surgical career. It's really because we've addressed a lot of the issues where the evidence that we've received has shown where some of the issues are. We know the quality of training, but we know that the product of existing surgery training remains very good and very high, but there are certainly areas where we can improve things. As Elizabeth pointed out, there's going to be a change in the way in which the team structure functions, that there will be more opportunities to get to the operating theatre and to undertake procedures without having the burden of ward work, which we know has very limited value as regard to career development. That is because of working with other members of the workforce will allow them to undertake those roles, giving the trainee the opportunity and the freedom to get on and do the things that they want to do. There's no doubt that we as trainers have struggled to provide the time available to us. That's partly because of the pressures from the employers to meet service targets, and the fact that it's more difficult to organise training lists, training clinics, and the opportunity for the necessary feedback. And within the programme, we're ensuring that the faculty, the trainers, actually do have the time within their working time in the week, the job plan, to be able to provide not only the training list, but also this sort of support, which we know is going to be advantageous, particularly in terms of the mentorship, the coaching, and the ability to feed back on a much more frequent basis than we've done hitherto. The curriculum means we've still got to have a series of regular assessments. Although the workplace-based assessments will continue, the latest recommendations or requirements from the GMC are to move a little bit away from what we've coped with in the last 10 years with the tick box approach, but a much more outcomes-based approach. And this is the ability to work in an outpatient setting and how you perform in an outpatient clinic in terms of seeing patients, taking history, doing examinations, but also your professional skills with your interrelationship with other colleagues, and for example, writing letters back to the GP. In the core curriculum for IST, we will continue to use the existing working assessment, but we are hoping that this different approach will again be advantageous. Talked a bit about simulation, the regularity of which simulation will be built into the working week. We recognise that that's extremely important, and not only regular access to simulation activities in the workplace, but also the inclusion of colloquially termed boot camps, but we're trying to use other words like education induction because of the potential pejorative nature of the boot camp. But you can see that it's that approach which has been done in the past, but not a formal part of training. The overall intention is that the job satisfaction will be enhanced, and some of that comes through the run-through process and also the intention of having longer placements. The posts that are going to go forward in August next year is intended that a trainee will largely work in one place for 12 months. They may rotate across different units, but the intention is that that will make life a lot easier, and particularly looking at work-life balance and planning outside activities in the context of the work programme. And there's also the potential that by having this greater access to the trainers and the ability to gain competencies, the trainees in core may begin to start getting ST3 equivalent exposure, and as a result gain skills more quickly. That may well allow trainees to proceed in through higher surgical training at a faster rate. We know everybody learns at different speeds, but we expect, and from experience in other specialties, we expect trainees to pick up these opportunities and move through at their own pace, but equally this may be with greater confidence as well as greater competence. Elizabeth's going to talk about the posts again, the sites.
Where will training be? Currently we have preliminary pilot sites, and the trainers and the local education training boards or deaneries have been required to submit applications and meet a variety of standards. Core Surgery recruits for England, Scotland and Wales, and the recruitment will be through that portal, and Debbie will talk about that shortly. Just looking at the posts, in the northwest there will be 3 posts, and they will be in Manchester and the Royal Liverpool and Broad Green hospitals. In the southwest, in 7, they will be in the Gloucestershire Hospitals NHS Foundation at Cheltenham. Moving round to Kent, Surrey and Sussex, they will be at East Kent and Medway, and there'll be 2 posts. In London, there will be 5 posts at Barking and in Croydon University Hospital. In the east of England, the 4 posts will be divided between Cambridge University Hospitals and the Norfolk and Norwich Hospital. In the East Midlands, Nottingham University Hospitals, Queen's Medical Centre or the Derby Teaching Hospitals, which will be the Royal Derby Hospital. Yorkshire and Humber will have 4 posts, and they will be the Doncaster Royal Infirmary, Hull Royal Infirmary, Northern General Hospital and the Leeds General Infirmary at St James's. Going to Wales, they will have 4 sites, and they will be putting in 8 posts. Scotland is intending to put in all of its core surgery posts to IST. There are 12 health boards and 27 hospitals in Scotland. 18 of these posts will be general surgery IST run-through posts. So trainees will go in at ST1 and run through and come out with CCT. The remaining 31 core surgery posts in Scotland will also be in IST, but these will be uncoupled for ST1 or for CT1 and CT2, and they will be in a variety of surgical specialties. But the aim is that all the core surgery posts in Scotland will be run on the IST model with a view to overall improving all of the training within Scotland. I'll now hand back.
I think just to follow up on what Liz has said, the posts have all been applied for by great enthusiasts who really feel that this is a terrific opportunity to do something slightly different, but actually I think with an awful lot of new and innovative approaches which we've tried to outline. So there's great enthusiasm from trainers who really feel this is the direction of travel. Debbie Beck is, as I say, lead from human resource point of view in the recruitment process within HE, and she's going to take you through how you can apply.
Okay, hello. So core surgery is a national recruitment. It's run by Health Education London in the South East, which is where I work. And all applications for core surgery and core surgery posts and the IST pilot posts will be made via one vacancy through the Oriel system. As you can see, the adverts are being published next week, and then the applications will open on the Oriel system on the 8th of November and close on the 30th. It's very important that you apply by the deadline because we don't accept any applications after that time. At the time of application, you'll not be asked to preference or make any selection in terms of the region that you want to work for, or if you want to be part of the IST pilot or not, or both. Which you could potentially want to do. That preference ranking will take place closer to the time of interview, and we'll advertise the preferencing window when we open the vacancy on Oriel. Information of how to apply via Oriel can be found by following the web link, and that will also link you to the vacancy once that's gone live on the 8th of November. And there's quite clear guidance as well there of how to do that. Prior to making your application, it's really important that you ensure that you meet all of the eligibility criteria. So these are all contained within the core surgery person specification, which is the same for the CST post and also the IST pilot post. You just have one person specification for both. And that can be found on the specialty training website, which we can link to after the webinar. And it's also important that you've read the Medical Specialty Recruitment Handbook, because that gives you all of the information of what you need to provide and the information you need to provide for your application. And it also holds lots of other information and resources that you might need depending on the on your answers to some of the questions in the application form. And then also when we publish the advert and the vacancy, there will be a supplementary core surgical applicant guide which is produced by London and South East, and that will be available on the adverts. There's the other links. So that's where you can find the person specification in the applicant handbook. And then the supplementary applicant guide will be available once the vacancy has been published. And it will also be available on our website, the London and South East website. So just a few things to note which might help you with your application as well. So communications from London and South East regarding your application and the whole recruitment process will take place via the Oriel system. So it's advised that you log into your Oriel account regularly during the whole application process, so you don't miss important communications from us regarding your application and long listing, and also the opening of preferences and interview bookings and things like that. And it's also really important that you have all of the documents that you're required to upload prior to starting your application, so you don't forget to upload them prior to submitting. Just one more thing on the preferences. So when we release the posts, it will be all of the posts that are available for core surgical training and IST pilot posts. But we are going to make sure that they're really clearly labelled on the system, but also there'll be a supplementary sort of spreadsheet on our website with all of that information contained within it, so you'll be able to easily filter by regions or post types and things like that as well, to make the preferencing process a bit easier.
Okay, thanks Debbie. I'm going to pass over to Lizzie Elsie now to give a perspective from the training point.
Thank you. So my name's Lizzie, I'm the Asset Vice President, and it's been a real privilege to be involved with this project, really right from the off, and there's been a whole team of us from Asset that have been involved in various work streams. So as we've already heard, this has come about because we know that there are problems with surgical training, particularly affecting core level. The GMC survey at core surgical training level have the highest rates of dissatisfaction amongst all trainees. The Asset Lost Tribe survey, which is currently published online at the International Journal of Surgery if you want to check it out, looked at surgical training experiences at core level and found that only 0.4% of posts met all quality indicators. So we know that there's an issue. And following the Shape of Training review, the Royal College of Surgeons of England were commissioned to develop surgical training and see if they could find a solution. So the solution, here's the solution: improving surgical training. And I think it's got lots and lots of potential to be great. There's improved rotas, there's a 1 in 10 on-call system, there's an aim to have increased elective trainee time. It's committed, engaged trainers that are signed up for this pilot. There's increased simulation access, and there should be wider team support. So lots and lots of positives in the potential solution. The particular gains as assets here is that the end point of training remains the same, and I know that Bill's already mentioned this, but it really is worth stressing that if you are an IST trainee, you will not be trained as an emergency general surgeon only. You will be trained in exactly the same way as the non-IST trainees in terms of the output of your training. Your CCT remains the same. There's been significant trainee engagement in this project, and I do believe that the project and the pilot has really got the best interests of trainees and surgical training at the heart of it. There will be a benchmarking process at the interface between ST2 and ST3 if you're a run-through trainee, and that currently will mean that you'll go through ST3 recruitment, as is normal practice for all trainees applying for ST3 posts, and if you meet the minimum appointable score, then you'll be able to continue on, and ASIT felt that that was an important point to make sure was clear. We do feel that there are some potential pitfalls, and that maybe some of these questions might come up from the audience. We have some concerns about the potential impact on training opportunities for junior specialty trainees. We think there's probably actually quite good potential to improve the core surgical training for the non-pilot trainees that also work in these posts. But perhaps some of these ST3 and ST4 trainees are particularly looking for training opportunities that they missed out on as core trainees might be impacted. As we've heard about run-through training, there are definite positives and negatives with this. One of the problems may be that if a trainee has a run-through post and their partner, for example, has a run-through post or a different post in another region, that run-through IST trainee may struggle with an interdeanery transfer process, and ASIT has some concerns about this. Clearly there are some ST3 places for 2020 that will be effectively assigned next summer at 2018 for the pilot trainees. And again, ASIT has a little bit of concern about whether there will be access to ST3 places for non-pilot trainees in a couple of years' time. It's obviously really important that we're able to report any problems that trainees are facing on the ground. And improving surgical training do have processes that they're putting in place for that. That's something that we feel really must be robust, so that pilot trainees, non-pilot trainees, other specialty trainees are able to really feed back effectively about how the pilot project is going. And then the question of future resources for rolling this out further remains a potential problem. So the future, we're glad to be having continued involvement, and we're looking forward to continuing to work with this pilot. We are completely behind any project that really supports the improvement of surgical training, and this hopefully will do exactly what it says on the tin, and we'd be glad to be involved. We're looking forward to the extension of the project to vascular neurology in 2019, and feel that evaluation of the pilot is going to be essential.
Thanks, Lizzie. That last point about the evaluation is something that we fully appreciate. We have to make sure gets going as soon as we start. We've already started putting into practice an evaluation of what we're trying to do at this stage of developing the pilot before we actually start next August or next October. That will be done by an independent group separately. We're under obligation to do that, not only for you to make sure what your experience is as good as it possibly can be, but equally the external stakeholders such as HEE, almost put some money behind this, and conversation I've had with the General Medical Council approvals group, very much interested in this whole process, but equally very much have your interests at heart to ensure that you're not disadvantaged by this. And I can assure you that the conversation we've had this week, we have good support from the GMC in that point, in that direction. So that's the presentation from us, from the four of us. I think we're now moving on to the FAQs. One point just to be aware of, that there's obviously a website that you can get information from, as you can see there, the English College website. And there's also more detail, as Debbie's indicated, about how to apply. Plus, there's a list of FAQs, and indeed, the discussion this evening, or our responses to the questions that you're putting to us, they will be included in an updated version of the FAQ following this webinar. So, we're going to move through and pick up questions. Right, so thank you very much for those that have sent us questions. these will, the ones on top of the ones that we've already put together to the FAQs, as I say, will be added together. So thank you very much. We've already had some. Right. Sorry, we're just trying to get the ones that you posed to us. First one up. Can I apply for IST if I don't want to be a general surgeon? Elizabeth.
For 2018, the IST will require you to, it's general surgery only, in England and Wales, and the plan is that from 2019, vascular and neurology will come on board. As we've talked about earlier, in Scotland, the uncoupled posts, and that will be 31 posts, will run similarly to IST, and so therefore if you're a general surgeon, but it would not be the run-through pilot.
Okay, next question. Will pilot sites offer only IST posts? Lizzie, do you want to try that one?
They will generally have a mixed bag, so there will be a couple of IST posts, and then the rest of the posts will remain standard, if you like, core surgical training posts. Just to stress again, as Bill mentioned earlier, that all trainees will be following the same core curriculum, but it will just be the training environment and opportunities that may be slightly different. As we've mentioned, we anticipate that if you are a non-pilot trainee working alongside a pilot trainee, it's anticipated that some of your opportunities may in fact be very similar to those pilot trainees.
And actually, I think it's hoped that the non-pilot trainees will also have an improved experience as well. And I think for some sites, that's one of the reasons they've been very keen to go in to raise their overall training environment.
I think that the issue really is the structure, which is the difference with the run-through. But there may well be some overlap and benefits from working in the same workplace. Next one. If I don't get an IST job, will I be disadvantaged? I'm assuming that question is based upon the fact that if you apply and you choose to wish to be considered for both an IST job or an uncoupled post, and you are offered an uncoupled post as opposed to an IST post, it may well be that on the ranking that occurs, which always occurs with course selection, that you have, by the time your position on the ranking is reached, that the IST jobs may have already been allocated. Therefore, disadvantage, the answer is no, because you would be offered, if you achieve the appropriate score in your core interview, you will be offered a core uncoupled training post, and as a consequence you will go through traditional core training, which, if you wish to do general surgery, obviously will be parallel to what's going on for the pilot trainees. If you're working in a site where pilot trainees are also working, we do not expect that the non-pilot trainees will be disadvantaged by the presence of the pilot trainees. There has been some concern, particularly in the context of rota gaps, that those in the pilot may be preferentially looked after, as it were. That is not what the pilot sites are intending to do. It's actually one of the reasons why we're looking to have the extended surgical team, surgical care team colleagues, who will be able to work alongside both pilot and non-pilot trainees in the same site, and that should be of some advantage. But equally, we're very conscious that we're going to have to watch this extremely carefully. Although the evaluation is being requested from outside, such as the GMC have said they want an evaluation come 2021, we think we will get information as to the way in which this is working really quite early on. There should certainly some information within the first 6 to 9 months and at the end of the first year, with a more formal outcome at the end of the second year. So it's going to be very closely monitored to make sure that things do not go astray.
Okay. Could I just ask, I guess one way that non-IST trainees may be disadvantaged would be their potential opportunities for ST3 posts in 2020. Do you have any thoughts about that?
The chart, I don't think they will, because I think the process, the benchmarking is the issue, which we recognise is important to ensure those moving from ST2 to ST3, there's a patient safety issue. So we want to make sure that those going to ST3, whether they come from uncoupled or from pilot, are at the same level.
Yes.
So, although there is the need to reduce the number of national training numbers for the ST3 entry in 2020, in actual fact, in the last 2 to 3 years of general surgery ST3 recruitment, not all of the posts have been filled.
Exactly.
So as a consequence, we do not believe that trainees who are in an uncoupled program are likely at a disadvantage when there's a pilot trainee who ostensibly runs straight through.
Thank you.
Next one. Will IST be rolled out nationally? If so, when? Perhaps I'd better take that because it's a slightly tricky one. Lizzie made the point that actually we're looking at a mixed economy. There have been a lot of discussions in a variety of committees. We've had 2 or 3 discussions on this at the Joint Committee on Surgical Training, and the overall opinion from both trainers, those who chairs of the SACs and trainees, is we must have a mixed economy. So that means that the trainee has the choice of whether or not they wish to go into an uncoupled training in core or to go into a pilot. And that's very much dependent upon your own personal circumstances, what you perceive you're going to gain from your core surgery training. It is interesting that certainly in neurosurgery, cardiothoracic surgery and maxillofacial surgery, where pilots have run-through programs have been in place for a small number of trainees, that these have proved extremely popular. ENT will be going live next year with its own run-through program that is separate from IST. And as you've heard, urology and vascular will be coming on board within the IST program. Now, it very much depends how this project works. I think that there will still be the need for a mixed economy. I think that everybody is different and will want to make their own decisions about how they wish to pursue their training. Certainly, by the time we do the evaluation, which will be 2021, I think we will know whether this is working. Because of course it is working, all we can say is we've tried it, we do not intend to disadvantage trainees, we're trying to hope that the initiatives put in place are making things better. But we do not believe that at this stage, that if IST does prove to be successful, it will be the only way of going forward. Because I think it's essential we have a mixed economy. Elizabeth.
I'd just like to say that I think we know that there are a number of trainees coming into core who clearly know the path they wish to follow. But there are other trainees who know they wish to become surgeons, but really need the opportunity in core to experience a number of different specialties and then be able to apply to ST3 in their chosen specialty. So I think we will always have to have some form of mixed economy for those who are undecided. And I don't think that means that they are any less committed. I just think they need the ability to have that opportunity. And of course, with reduced numbers of surgical posts in foundation, a lot of surgical trainees will not have done the surgery that they would previously have done and may not have had that opportunity to find out what they really are interested in.
I suppose the other point to make is that IST pilot trainee who's enrolled on the general surgery pilot scheme, who then decides they'd like to do orthopaedics or plastics or whatever, is completely free to resign that number and apply ST3 recruitment for their chosen specialty.
It's one of the things that we've had to address within the application for approval by the GMC to build in flexibility. So if you do start and you've been doing your training for 12 months, you really don't like general surgery, there will be the opportunity to move into one of the other specialty areas. So it's not, you've signed up for 2 years, you can't move from that. You will have that flexibility, and that's a key component.
And that will always have to stay.
Yes, yes. Next one. Would I be able to work less than full-time in an IST post? Debbie, Lizzie?
Well, yes, they can. So the arrangements will be the same. So you'll be able to still, I presume, defer and still work less than full time and apply for any special circumstances and things like that, which may be that anyone would be entitled to is going into a core program, not just in surgery, but in all the other specialties as well. Information on those different sort of things can be found in the Gold Guide, but also in the Medical Recruitment Applicant Handbook. So how to apply for all of those different pathways are definitely available in that. Explained in the handbook.
For those of you who don't know, there's a document called the Gold Guide, which if you can't sleep is possibly worth reading. It's a little bit soft, but there are some very key areas of advice about the whole of the process of training. And the less than full-time training issue has been something that we in JCST in the last 12 months have taken extremely seriously and have just published our recommendations on less than full-time training in surgery, because it was perceived we could not do it in surgery, but in fact we can.
And similarly to other aspects of the Gold Guide, as Debbie alluded to, if you would like to apply for UPAR, out-of-programme research or training or experience, or the application process remains exactly the same as for non-pilot trainees. All training is governed by the Gold Guide, so that's uniform.
The Gold Guide is actually quite easy to search, so you don't have to read the whole thing.
That's quite right. There's a new version going online shortly. Next one, please. How many pilot site posts will there be? I think Elizabeth sort of
we've covered that, but I think it will be 81 in total. And the 8 in Wales, we expect 24 in England, and the Scotland with the mixed economy. And that's the 31 IST run through in general, the 18 run through general surgery in Scotland, with the 31 the uncoupled in the general mixed economy.
The intention of the whole project is that this is our first year, 2018. We do have other sites that are interested but haven't quite met the criteria, who will be coming on stream for 2019 general surgery admission, as well as those in vascular and urology, as we said earlier. So it's not just a one-off process next August, it's actually a rolling programme. Next. Will it be harder to get into IST pilot than core posts? Might going to take that. The intention is that, and this is something that we discussed at some length in the early phase of the project, that if you're trying to make a difference, should you have a so-called enhanced selection process? Well, we took the view that actually that probably would not be a good idea, because we're obviously in the evaluation comparing those who run through the pilot and those who go to uncoupled core. So to make it a valid evaluation, you could not make a difference in the way in which selection occurred. So that is why once you've applied and are longlisted for interview, you will go through identical process of selection. And it's only after that, when the results of the application is known and your position in the ranking is known, will the choice of whether it's an IST or an uncoupled core post will come into effect. Obviously, the logistics of it Dave's given reference to, but the selection process will be identical. It is competitive. Getting into surgical training is competitive, but it's not going to be more so purely to get into an IST pilot. Next one. What will be the main differences between IST pilot training and core surgical training, Lizzie? Perhaps?
Yeah. So I think that one of the key differences is the run-through aspect of the improving surgical training pilot. As I've mentioned, you will have to go through ST3 recruitment processes to make sure that you meet the minimum appointable score. But if you meet that minimum appointable score, then you have your post secured. The other main differences are that the environment in which you're training will be different. So there are specific indicators for the improving surgical training post, such as a rota, which is a 1 in 10 rota, the wider surgical team support, 60% of daytime activity having trainee-trainer contact time, those sorts of things, access to simulation, are different and specifically set out in the improving surgical training pilot as opposed to regular core surgical training. As we've mentioned before, and I think it's worth stressing again, the end point of training, the CCT, at the end of specialty training remains the same for both IST and non-IST. Another key difference is with the improving surgical training pilot is that people may be able to progress through training slightly faster if they are having these enhanced opportunities for training, and with changes to the general surgical curriculum becoming truly competency-based may mean that you can complete training in a shorter time duration than somebody who was not on that situation. However, all specialty trainees will be switching to the new general surgical curriculum in the future. So that also does apply to non-IST trainees.
The whole principle is the difference will be a greater attention to getting over the service training interface, because that's what we perceive from all the evidence we've had and all the discussions we've had has been the main reason for trainees' dissatisfaction and the issue around encouraging trainees to take up general surgery. You've actually got 3 general surgeons by background in front of you with different specialty interests, so we've been through it, some more recently than others, and it's these opportunities which I think we recognise we're trying to make as good as they possibly can be, and that's why we're so keen to promote this opportunity. Next one. Will this be extended to ENT? I've heard rumours of run-through ENT from 2018 in certain pilot areas. If so, which areas are these? Right. It is, I accept, slightly confusing. The original process of the IST project was based in general surgery. ENT, as I've indicated earlier, have decided they would wish to look to run through for some of their posts. There will be 4 sites in the country where these will be done, and they will be advertised in the same way as the core post, be they pilot or uncoupled, in a week or so's time. So therefore there will be the opportunity to see whether or not you wish to choose ENT, and these will be in KSS, London, the North West and the West Midlands. Similar to what we're doing in general surgery, it is only a small number of posts. We have looked across the country, but ENT have decided that they will do theirs in these 4 programs, but they will not be going along with the initiatives in the IST pilot that we've done in general surgery. It's just one of those things that's happened whereby the initial planners all worked around general surgery, and ENT have taken a leaf out of the book of their colleagues in cardiothoracic neurosurgery and OMFS, because they want to see if they can train in a run-through manner as those other 3 specialties have done. In the restricted training period, there's a chance to never see some surgeries. How are we going to cope with that? I'm not quite sure the meaning of that. Elizabeth, perhaps you
I assume that they're saying that there are some specialties, say upper GI, or more specialised areas like endocrine, that you may not see, and I think that is very much the case, and I would hope that your training would be modified to your needs, as it presumably is at the moment.
I think, yeah, I see the point. I think the first 2 years is very much an expectation you meet the competence as described in the core surgical training curriculum. Once you get into higher general surgical training, then the intention is that throughout that period of time from ST3 through to CCT, on the one hand, you'll be continuing to have your emergency general surgery workload, but you'll have the opportunity to develop your subspecialty interest. Now, to a certain extent, in the first couple of years of higher surgical training, the majority will be doing the breadth of abdominal general surgery, be it upper or lower GI. And then you will have the opportunity to make a judgment as to which direction you would prefer to go with your subspecialty training in the latter 2 years. I hope that answers that question, but we can always come back to that. Can I apply for an interdegree transfer on the pilot? I'm going to have to ask Debbie to do that because I don't understand.
So interdegree transfer is a national process which is actually also run within the London and South East Recruitment Office, and there's really quite strict guidelines as to when you can apply and when you're eligible. There's 3 eligibility criterion, so you have to meet those and be able to provide evidence of those as well. And also, I don't think you can apply within the first year. So if you're on the IST pilot, I presume you could, because you also can't apply in your last year of training. So normally in core training, you can't apply for an interdegree transfer because you're not in the post long enough. But I presume with the IST pilot that may be a possibility, but it would be something that would have to be looked into at the point of application.
And would that have to be an IST pilot switching with another IST pilot post? So they were mirrored?
I would say it would be, but I think that would also be something that we would potentially need to look at, because if it was with an IST pilot but there weren't any IST pilot posts in the place that you wanted to move to anyway, because there's some regions which haven't been involved, and so you wouldn't then be able to move to that region. But I don't know whether that was something we'd have to investigate. But for an interdegree transfer, there has to be a vacant post in the region you want to go to anyway. So whether it would have to be an IST pilot post or whether we could identify another vacancy, but then it may be that you'd have to come off the pilot to move.
Well, it's obviously case by case, but equally, in fact, on the basis they would have to be in post for 12 months, that then takes us to 2019, and we'll have more opportunities come 2019. Yeah. So there's a bit more posts to choose from. So it might actually solve that one.
Yeah.
Okay. Will themed CT jobs still exist? Now, those, if you're saying head and neck, that is there's been a lot of discussion over the years between themed or generic core training. What this pilot is intended to do is to be really a themed general surgery program. The head and neck post to which I think you might be referring would be within ENT. Although ENT is doing run-through, there will still be uncoupled ENT themed and indeed ENT generic opportunities. So yes, those posts will still exist, but they will probably, I think, be more available to those in uncoupled training as opposed to the IST project group. Does that make sense?
That's very likely.
Yeah. So yes, they will be, but not within the pilot. Will 60% training per week and a 1 in 10 rota be stringently upheld? What measures are in place to hold pilot sites to account on this? I better take that.
Yeah. Looking right at you.
Take it in 3 bits. Will 60% training per week be upheld? Yes. And a 1 in 10 rota be stringently upheld? Yes. We've just gone through all of the applicants for the posts, and there were 3 themes that were recurrent that we pinned those who are applying to host the post down to. Rotas was one of those 3. The other 2 were making sure faculty had adequate time in their job plans, and the other was the introduction of the non-surgically trained workforce, the EST group. And so, as a consequence, we have stated in the document that the only way you can get the 60% is to be in rotas of that size. And as far as the project board is concerned, we will be using the information that we get from a variety of sources. The trainees, obviously, are those who are most aware of what's going on. The training program directors will receive information back from the educational supervisors. The SAC and general surgery liaison members will get that information. But I think we on the project board realise we have a huge responsibility to make sure these issues are absolutely in place. And I think we would be quite concerned if this occurred and there are issues around rota gaps, etc., the standard problems. I think that would mean we would have significant concerns about continuing that process. So those really are the measures I think we would put in place to hold parallel sites to account and to make sure that what we want to happen, which is the whole crux of this, to make sure, as I said on a couple of times, it's the interaction between training and service, that the training takes the priority. And that's what I think we would wish to be quite firm that if it looks as though this is not happening, then I think we would ask the heads of school to move the training.
Can I ask a little supplementary question to that? So money makes the world go round, and trainees that are on a 1 in 10 rota may find themselves financially disadvantaged compared to a trainee on a non-IST post who's a 1 in 6 rota. Do you think, is that a possibility? Have we looked at that?
It's come up in discussion, yes, and we are aware that that's a potential risk, and I think trainees need to recognise that.
That's an important point for trainees' decision applying.
Certainly. They're looking at the way that the 2-year programmes have been put together, there may be greater dependency in one of the years as opposed to the other, so it might balance out. But again, it's something that will have to come out in the evaluation. Next one. Will it be the same interview process for IST and non-IST trainees? I think we probably answered that.
Yes.
Yes is the answer. I get it.
Very, very definitely.
No preference one way or the other. Can you elaborate on what will be the exact role of non-medical healthcare professionals in the surgical team and how exactly will this contribute to improved training experience? I will give personal experience of what's happened in my own institution. I work in a tertiary referral cancer centre, and we had an awful lot of criticism levied back to us from the TPD, from the ST2, saying they were getting no experience in the operating theatre because they were stuck on the ward. We managed to find some enlightened senior management who were prepared to employ an advanced nurse practitioner on the ward. And it came home to me, I was doing a subtotal gastrectomy for cancer with an ST2 trainee and taking through different facets of it. The phone kept going, and in the end I said, what was that for? And we found out it was to write out the P-plaques for someone's bowel prep for the next day. Complete nonsense. And what's happened, having employed the advanced nurse practitioner, it's revolutionised the experience with the ST2s. They do not have to put up with all this additional stuff of non-contributory activities, where the ANP, who is actually ex-CCU trained, relishes the opportunity that she has got. She's been off on maternity leave, and we're very grateful she's come back, because it's back to normal. It does make a huge difference. Now, there are concerns being expressed that these individuals will need training, and there's a potential for that overlapping with the training for the surgical trainees. This is something we're very conscious of, and in all the models that have been looked at, because there's quite a lot of experience in different parts of the country of how the extended team will work, that they will be trained in different ways to address the issues that they need to have for their work. An example has been in cardiothoracic surgery, where surgical care practitioners have done the vein harvest, and they've needed to be taught how to do that. With the opportunities that we're putting into the programme, not the least being simulation, but also this additional available time in operating theatre, we are pretty optimistic that the logbooks of the trainees will be significantly better than we've had hitherto. I don't know, Lizzie, you've got a point there.
Do you think we've got enough wider surgical workforce, and what are the requirements of the pilot sites? Do they have to have 1, 2? How many have they got to have?
As things stand today, the answer is we don't have enough. But there are significant numbers in training, and it is anticipated there will be sufficient available to support the pilot come start time next summer. Because the Part of HE's work is to expand the workforce, and that's an area that they're looking at. And it's making sure that it complements rather than overlaps and competes with.
I think that's been one of our concerns.
Yeah, I appreciate that. And I think that we recognise that, but the roles that are being envisaged, and when you talk to the leading authorities, be they from the nursing background, from a radiographic or pharmaceutical background, pharmacy background, they will realise what their responsibilities are to minimise that. As regards to the numbers, to a certain extent, that is actually down to the employers, and we've had lots of conversations with employers. As I said earlier, we've looked at all the applications and have been reassured that those that are being selected to host the pilot have got the necessary numbers. Again, part of the evaluation because it is a pilot. We've been going for an hour. We're going to send you a short feedback survey, and we really would like your feedback on this. It's new ground for us, whether it's made an improvement in your understanding of what the project's all about. Can you let us know what we've done reasonably well at, what we didn't, where we think we can do better? It therefore really remains to me to thank Elizabeth, Lizzie and Debbie for their support and answering the questions. This is an ongoing process. I've considered it to be a dynamic process. It's taken us 18 months to get where we are. It's very, very exciting that next week we're going to actually advertise for this post. It's been challenging, but we really do think that we've got the best interest of trainees at heart, and I think the opportunities that this process and programme has on offer are far better than we've actually had for an awfully long time in surgical training. So we're very grateful for your interest in taking part. Please continue to throw questions at us, and we'll update the FAQs as we go. So thank you very much for joining in. Good evening. Stop filming, sorry.